This discussion will focus on differentiating stroke alert versus rapid response versus code blue. So with the stroke alert, there are different criteria you have to look for, and you have to assess your patient using BFAST. So with BFAST, it stands for B as in imbalance, E for eyes, F for facial droop, A for arm or leg drip, S for abnormal speech, and T for the time. So you have to look for the onset. When did it start? Now, for other criteria, if you have any suspicion of head bleed, like subarachnoid hemorrhage or intracerebral hemorrhage, you have to look for signs like sudden, worst ever headache, sudden or unexplained decreased level of consciousness. And once you see all of this, and also changes with Glasgow Coma scale. So any changes of this or any abnormalities, you have to call stroke alert right away. And this stroke triage assessment tool is created by Florida Department of Health, and it's updated last year. The previous stroke alert assessment tool it looks like this. So this is the stroke alert checklist created way back 2004, and as you can see, there are a bit of changes here when you look at the newest one, which it added the possibility or suspicion of any subarachnoid hemorrhage or intracerebral hemorrhage. Okay, and this is way back 2004. Now, the next one is knowing when to call rapid response, or also known as rescue alert. So there are different criteria that you have to know as a nurse, like for example, heart rate over 140 or less than 40 beats per minute, respiratory rate over 28 breaths per minute or less than 8, systolic blood pressure greater than 180 or less than 90 millimeter mercury, oxygen saturation less than 90%, acute change in mental status, urine output less than 50 cc or 50 ml over 4 hours, staff member has significant concern about patient condition. Additional criteria would be chest pain unrelieved by nitro, threatened airway, seizure, or any uncontrolled pain. So all of these criteria, you have to know that once you see it, you have to call rapid response team. And remember, you don't really need to bring crash cart right away at bedside unless your patient is having dysrhythmias or any cardiac or pulmonary problem. Or let's say your patient's having seizure and there's a possibility of intubation. That's the only time you bring crash cart at bedside. Because remember, crash cart, there's only 1 or 2 per unit. So if you use and you open one crash cart already, you cannot use that to other patients. And you have to change the whole thing and bring that to the pharmacy and have a new one. So as you can see, it's not cost effective bringing crash cart all the time when there's a possible rapid response in your unit, unless it's needed. And remember, when you look at rapid response criteria, your patient is still conscious. Once your patient becomes unconscious, then you have to call code blue. Now, the reference of this rapid response system is based on AHRQ, or Agency for Healthcare Research and Quality, and it's just updated last year. So the other criteria that you have to know, and these are for code blue. If your patient is unresponsive, not breathing, pulseless, that's the only time you call code blue. You push the code blue button, you do immediate CPR, your other part of your team will bring the crash cart for you and put the patients they will put the defib pads, put the patient on the monitor, start giving medications based on the need or based on what dysrhythmia your patient's on. And then the code blue team will come in. Remember, rapid response team and code blue team are different teams in the hospital, and each teams has a group of nurses, group of physicians, respiratory therapists that will help you to manage your patient and to stabilize them. And remember, rapid response, going back to rapid response, it's created to decrease morbidity and mortality of the patient. So all of the criteria that we discuss about stroke alert, rapid response, and code blue, you have to know that as a nurse.